Good morning, everyone. I'm Shazia Shabir, your moderator for today's session. On behalf of Neuroptech, I want to welcome all of you and thank you for joining us. Really appreciate the turnout today. But before we start, just a few quick instructions so the session runs smoothly. Please keep your mics muted throughout the talk. You don't need to switch your camera on. If you have any questions, just drop them in the chat whenever they come to your mind and we'll take all of them together at the end during the Q&A. Please do not raise your hand and do not interrupt the speaker. Now moving ahead, today's session is on basic squint evaluation in daily workup. This is something all of us face in clinics, but it rarely gets explained in a simple, practical, or step by step way. So, hopefully, by the end of this session, your approach to strabismus evaluation becomes clearer and more confident. Now, it's my pleasure to introduce our speaker. We have with us Ms. Ashwin Shobitha. We have with us Ms. Ashwin Shobitha P, consultant pediatric optometrist at Narayana Nethralaya Super Speciality Eye Hospital. She has completed her Bachelor of Optometry and works extensively in pediatric eye care and squint evaluation. She handles a wide variety of strabismus cases every day. So we're definitely going to learn a lot from her practical experience. Ma'am, thank you so much for being here with us. You may begin the session now.
Yeah, thank you, Ms. Shazia. So, whether my audio is clear?
Yes, ma'am, it's clear.
Okay, I will just try to share my PPT. Sorry, I'm not getting the access to share my PPT.
Share your screen, and that way we can see your PPT.
Yeah. So, can you see my screen?
Yes, yes, your screen is visible.
Yeah. Okay. So, first of all, thank you for Neuroptech for giving me such an amazing platform. So today I'm going to present a topic based on squint evaluation in our daily workup. So at the end of the section, we will get to know how we are going to do this examinations and your skills as well as your everyday basic things can be evaluated and your skills will be upgraded at the end of the section. And I can assure you for that. So without any delay, we can go into our topic. So, why and what is the need of diagnosing strabismus? It is always early treatment, early investigation, and early diagnosis is a key factors for every disease which we are going through. So, in the strabismus case, also it is same investigation and diagnosing. It is in the early age of 1 to 4 years of age. It is a critical time, and diagnosing it and then treating it at the early of 6 years to 8 years will give you a much more effective result than in the early age. So we all knew that deprivative amblyopia and the deprivations, those things will be end up at the critical age of 8 years. So what we can expect from this presentation? The first one, we are going to cover up all the basic things. The second one, we are going to see some examination which you can do in your daily practice. It's a very minimal time consuming examinations which you can do in a quick assessment in your daily workup which enhance your practice level. And then we have a little bit of ritual class where we can put all those examination into our practice. So we can go into terms to make sure whether the terms are a bit easier for us, to make sure the terms are a bit clearer for us. So I will just slightly catch up with all other things. The first one, we are going to see about the types. So types, if you say it, we have different types of deviation. The first one will be iso deviation, exo deviation, which is inward and outward deviation of the eyes. The next one will be hyper and hypo, which is an upward and downward deviation of the eyes. So one eye will be deviated from its primary position or visual access point. Then we are coming into terminologies. The terminologies which we are speaking about: constant, intermittent, and alternate. Constant in sense, like for example, if you in your right eye you have deviated towards outwards, and it won't alter to the other eye, it will be constant to one eye itself. And in intermittent, the eyes can alter one thing, and it can be various in the distance and the frequency and the timing, it will be varies. And when you come to the alternate squint, so alternate, it depends from your eye to eye, that one eye will be deviated sometimes and the other eye will be deviating sometimes. The fixation will be keep on varying, and this kind of intermittent and alternate squint, the patient will have tend to have some good amount of vision in both the eyes. And then terminologies like duction and version. Duction and version, pretty confusing topic where people will be getting easily confused. Like duction is also an extraocular mortality, version is also our extraocular mortality test. But the only difference between these two is duction we are doing monocularly, and while version we are doing binocular. So, what is strabismus? Strabismus, we can simply put into the term like it is a misalignment of the eyes, or else one eye is deviated from the primary position or the visual axis. The word strabismus is derived from a Greek word which is called as strabismos, and it has meaning into it. So when a word strabismus comes into your clinic, or a person with strabismus which comes to your clinic, what are the things you have to see? Majorly, we have to see four things. The first one will be the direction. So, which direction the eye is deviated, which is a primary most important thing which you have to observe in your daily OPD. The next one is a state of fusion, and state of fusion we always sees in intermittent and in alternate squint, where the patient can able to fuse it together. In some cases, they have a very good fusion, so the patient does not have any deviation where you see in a normal eyes, unless or until if you do some examinations to break the fusion and to make visible the squint is. And then competency, in competency we have a concomitant and incombinant, which is a paralytic and non-paralytic squint in a layman term. So today we are going to see everything on the basis of non-paralytic squint and the evaluation about non-paralytic squint. Maybe in future we can go with the paralytic squint options as well. And then laterality. Laterality, it is simply put into terms like whether it is a unilateral or bilateral, whether it is shifting or if it is not shifting. And then evaluation part. So hope other basic things will be coming back into your mind. So now we are going into the evaluation part. So evaluation part has been simply splitted into two types, which is a sensory evaluation and a motor evaluation. In sensory evaluation, we have corneal reflex test, which is also called as Hirschberg test, and stereopsis and Worth-Ford dot test, Maddox dot test. In this stereopsis, Worth-Ford dot test, and Maddox dot test, you need patient's response. So explaining the terms and explaining the procedures is way too important in this case, in this test, so that the patient can easily understand and they can give you an expected response, whatever you want. And then the motor evaluation, it is an objective test. You don't want any patient's response in the motor evaluation. So in that you have cover test and extraocular mortality test. So in the virtual class, we are going to put in action about this corneal reflex, cover test, and extraocular mortality test in the in the virtual class, so that you will get a better idea of about those things. So without any delay, we can kickstart into our evaluation part. The first part will be a sensory evaluation. So sensory evaluation, the first and foremost test will comes into Hirschberg. Before coming into Hirschberg test, I just wanted to highlight a simple history of Mr. Hirschberg. He is the one who had been introduced this Hirschberg cornea reflex test. Late in his time period, he had been testing with various things to evaluate the squint and other parameters. And finally, he came with an idea of testing cornea reflex with the help of candlelight. He used to see the candlelight reflex in patient's eye, and based on that, he documented the cornea reflex. And those things have been evaluated now. And instead of candlelight, now we are into torchlight, pen light, and so other things. So, how we can perform this? Hirschberg test is also called as cornea reflex test S, because it is primarily based on cornea reflex parameters. So, it is an objective test, as I've already said. Here, patient's cooperation is needed, but patient's response is not needed. And it estimate the angle of manifest squint. Manifest squint, it is an squint where you can able to see it even without any test. And it falls under the first Purkinje image. We all knew that we have four Purkinje image uh, in our eyes. The first Purkinje image will be the anterior cornea reflex, which is important. And based on this reflex, we are going to test it. And it is very useful in young, uncooperative, and even in people who have poor vision, which is less than 6 by 60. It says like 1 mm of every decentration of cornea reflex from its center point will give rise to 7 degree of deviation from the visual axis, which can be measured or which can be approximately put into 15 prism diopter. So how we have to do this? I have kept a small diagram over here. So you can see a person with a light over here. So make sure you have to place the patient straight, and as a patient to sit comfortably straight, and you have to maintain your eye level straight to the patient's eye level, and shine the torchlight in front of patient's mid eye, in between eye. So you have to place the torchlight straight in front of your eyes, in front of your nose tip, and then you have to shine the light at the middle of the eyes. So if I put here, it will be much bit more easier. So here you have to shine the torchlight. So I hope you can see my laser beam. Is it visible?
Yes,
Is
ma'am.
my
It is.
laser?
Yeah,
Yeah.
it is visible.
So here you have to place the light and ask the patient to see at that light. So while the patient is seeing the light, you'll be seeing the examiner, like optoms, you will be seeing the cornea reflex. So if the cornea reflex at the center, it is said to be a center or a normal cornea reflex. If it is in the outermost part, then it will be an ESO deviation. If it is innermost, then it is exodeviation. If it is down, it will be an hyperdeviation. And if it is up, it is an hypodeviation. And always remember, the cornea reflex will be opposite to the eyes deviation part. So we know how to do it. Then how we can measure it? So measuring, we have to see the cornea reflex. We have to observe the cornea reflex where the cornea reflex places on. If it is exactly center, it is 0 degree. It means an ortho or a center. If it is on the pupillary margin, then it will be 15 degree from the central deviation. And here somewhere, like in between 0 and 15, here somewhere will be having a 7 degree of deviation, which in your daily practice you will get to know how to point out 7 degree and 21 degree of deviation. So if it is in between the pupillary margin and limbus, then it will be 30 degree of deviation. If it is in your limbal part, then it will be 45 degree of deviation. If it falls on the scleral part, then it will be 70 degree of deviation. This 70 degree of deviation is quite rare whenever the patient have any paralytic or full restriction of the eyes. In that cases you will be having a 70 degree, or else the 0 to 45 degree are quite common in your daily practice, and 21 degree will be in between 15 degree and 30 degrees, somewhere here it will be. So in your daily practice, if you keep on practicing, you will get an idea where it is. So I hope this measurement is quite clear. And then we have a small tips. So to make it in a small quick points, I have kept it as a quick tips where cornea reflex will always be opposite to the deviation of the eyes, as I've already said, and higher the deviation, more cornea reflex decentration. It means how much ever your cornea is decentrated either out or in or up and down, the reflex will be more decentrated according to that. So our next test comes in is stereopsis. Stereopsis is roughly called as a grades of binocular vision. So binocular abnormalities will also affect the stereopsis. So stereopsis has two properties or two forms in it. One is binocular disparity and another one is monocular clues. So now we are going to see about binocular disparity, where this strabismus can affect your binocularity. So what is stereopsis? Stereopsis is the perception of both the eyes. When your both the eyes will see same image but slightly different from both the eyes, what happens, your brain will take the image, will capture the image from both the eyes, it fuse together, and it will be producing a two-dimension or three-dimension image. And this is how the stereoscopic image will be produced. And how to measure it? To measure it, we have a stereo acuity test. So how this stereo acuity test can be measured? It is an angular measurement which will be detecting your minimal resolution. It means your minimal ability to differentiate between these two images, to between these two dissimilar images, and this can be ruled out with some other test and some other books which we are going to discuss further. And normally we used to say the normative value of stereopsis will be 40 seconds of arc, where your both eye will have an equal visual acuity. So 40 seconds of arc is a normative value, but even patient can have less than this or even more than this. So how we can measure it? So we have different types in it. The basic test which we are using worldwide, or this 4 and 5 test. So titmus test. In titmus test, we use a polarized glasses, and we used to see, we ask the patient to see each images, the popping circles or popping flies, and we have to ask the patient to catch it or to point out on the popping things. So this will be giving you an idea of 40 seconds of arc from 800 seconds of arc, and so on and so on. And it is very useful in pre-verbal children's as well, and school going children's as well. And then we have Randolph stereogram, which is a wild word and a standard test which we use every OPDs, I guess. And then even in this Randolph stereogram, we used to use a polarized glasses. And we have another test which is a TNO test. Even in this test, you will be having a popping letters, so the patient can able to see this with the help of polarized glasses. And this all three test is based on a polarized things, where you're using a polarized glasses. Without the glasses, it will be quite difficult for you to understand or you to identify the dissimilar images. So what happens and why we are using this polarized glasses? It is a way too simple, like your one eye will be capturing your horizontal disfigurement, and your another eye will be capturing your vertical dissimilar images. So both these dissimilar images like vertical and horizontal will be fusing together, and it will produce a stereoscopic image. So this is how this stereo acuity charts will be performed. And the other one, we have Lang test. In this Lang test, we don't want to use any polarized glasses. In our naked eyes, by tilting it up and down or either sides, we can able to perceive these images. So the whole chord will be just like this kind of dots, the whole chord. And when you're flickering here and there, at that time you will be seeing this kind of shapes. So this is quite easier in our kids who are less than 4 years or less than 3 years of age, so that they can able to see objects, they can able to grab those things, they will be quite interesting with the shapes. So this stereopsis test will give rise to 550 seconds of arc, and it is an initial screening test where it will gives you an idea whether the patient has any stereo acuity. If they fail to capture it, then it has been marked as negative stereo acuity test. And the other test, we have two pencil test, which will be widely used in CAMS and in your basic screening test. In that test, you'll be holding two pencils and you will be asking the patient or the person of examination to hold the pencil and to hold the other pencil and to make the pencil coincide together at the same point at the first attempt itself. So this will be giving us an approximate value of 2000 seconds of arc. So this is how we used to measure stereopsis. So the our next test is word for dot test. Word for dot test is also a common test which takes a few quick time process, and it is very useful in detecting all these three uh, things in your eyes, which is abnormal retinal correspondence, diplopia, and suppression. Whenever your binocular parameters affects, these parameters will also affect. So in this test, we are going to use some filters. So the filters are red and green. So we will be using this for the both distance as well as for the near. So in this right eye, we will be using a red color filter, and left eye will be using a green color filter, or goggles also is fine with the same procedures. And this light is used for the near as well as for distance. And in most of the clinical practice, we have this images, or we have this kind of patterns in our system itself. So how it works?
So here's how it works. The patient wears red-green glasses. Then they are presented with 4 dots, 1 red, 2 green, and 1 white. The colored dots will get canceled out when viewing it through the colored lenses, and so each eye sees a different combination of the 4 dots. The white dot is seen in both.
So this is how it works. Each filter will cut off the other color. So the white will be the commonest color which can be observed in both the things. So how we can interpret it? So while interpretation, as I've already said, the red color filter will always be in your right side, and whenever you're seeing through the red color filter, you'll be seeing 2 red dots, and whenever you're seeing through the green color filter, you'll be seeing 3 green dots, and it will be fused together. You will be getting this 4 circles of diamond shaped patterns, and you have to ask the patient how many colors and how it has been placed, and what is the image look like, so that you will get an exact interpretation of what patient is going through. So the patient will be having 1 red at the top, 2 green at either side, and 1 pink or red and green flickering in down. So in case if the patient sees only 3 green, what it is? So if they can able to see only 3 green, it means the right eye is suppressed. If the patient can able to see 2 red, so it means the patient can able to see this 2 red in the right eye, and the left eye images has been suppressed. So it means the left eye is suppressed. Now some people can say, I can see these 2 colors, but I can see 5 colors. It is not in focal. like 5 circles, but it is not a 4 circle. In that case, you have to ask the patient where the color is, whether the right side color images is in your right side or in your left side, and how they are placed and how they are arranged. In case the patient says the right image is on the left side and the left image, that left green color is on the right side, it means the patient has a cross diplopia. So cross diplopia is always ended up with exotropia or exodeviations. In case it is not crossed, it is in the straight away of right image is straight into your right side, and the left image or green image is straight into your left side, it means uncrossed diplopia, where the patient can able to see two image but it is uncrossed, and this uncrossed diplopia will always seen in eso deviation. To just put it in a smaller point of view, if you think about x, that is exotropia or exodeviation, always remember it will be like a crossed diplopia. But in some cases, as I've already said, a Watford dot test must be done for both distance as well as for near. So in that cases, some cases like people can say different options or different interpretations for distance and near. All this tests like cross and cross diplopia suppressions will be same for both distance as well as for near, but except one term. In this case, a patient can say for near distance, he can able to fuse it together. The patient can perfectly see one red, two green, and one red and green or pink color. But the other, when you go for the distance, the patient can see only three green colors or only two red colors. It means like either one eye is suppressed. It is a clear indication of monofixation syndrome. So, what is monofixation syndrome? Or monofixation syndrome, in a simple and 1 minute quick revisions, what it mean is monofixation syndrome is something like a patient will be developed with a small degree of scotoma, which can be neglected by your brain. And whenever you're doing this test for near, it does not falls on the scotopic area, the images on the right and left, so that you can able to see a fused image. In case for the distance, your right eye is affected and the right eye image falls on the scotopic place. That's the reason the patient can able to see only the left eye images. So the right eye is suppressed. This is a small um, thing where you can able to see in your daily practice. So in case if you have this kind of uh, evaluations, it will be much more easier for a better conclusion or to get a better interpretation of what exactly happens to patient's eye. So monofixation syndrome, it has lot into it. If you go into a detail, you'll be getting a much more idea about it. So our next test will be Maddox rod test. So Maddox rod test is also a subjective based test. We need to explain the patient how it works, what they used to see, and what expected answers we will get from them. So it is basically based on a principle of diplopic projection. So it will be measuring both phoria and heterotropia, that is both hidden as well as non-hidden squint. So this Maddox rod consists of a plano parallel convex cylindrical lenses. It has been placed in such a way you will be seeing a line concentric patterns in a metallic disc. So usually worldwide will be using a red color Maddox rod, which is easier for us and for the patient to see the difference between the color, and based on that they will be saying it. And even we have different colors of Maddox rod like green, white, and other colors as well. So Maddox rod produce a linear images which is opposite to the axis. So this video will give you a better idea of it.
We are placing Maddox rod.
So now it is placed. So if you see, the Maddox rod is placed horizontally and the line is in vertical. So if you rotate the lenses and place in front of patient's deviated eye vertically, you'll be seeing the patient will be seeing a horizontal image, and this is how the patient will be seeing it. The patient will be seeing, and we have to measure it according to that. So it will be giving you an idea which type of deviation it is. As we already said, when the light is on the right side, because here the patient does not have any filters in the right eye, so the left eye has the filter. So here the patient sees a light here and the line in the left side, so that it is in the same side, it is not crossed, so it is uncrossed. It gives you an idea the patient has an ESO deviation. So here the right eye image is on the left side and the left eye image on the right side. So if you see the patient is seeing
Ma'am, you're not audible. Ma'am. Shobita ma'am, can you hear me? I think there seems to be an issue.
the line is down and the light is up, it means the patient has a hyperdeviation. And in this test, we also examine and we can also measure it with the help of Fourier chords. So these are the Fourier chords which can be done for both distance as well as for near. This small lines and small numbers will be used for near, and this big numbers will be used for distance. This will be the light will be placed at the center of this point behind the pad or behind the cord, so that we have to ask the patient where the line coincides, at which point the line coincides, whether it is on the number, and we have to ask which number it is, and based on that we'll get an idea. So as you can see, it is an esophoria, and here you will have an exophoria, and based on that patient will be having um, crossed and crossed, and you have to ask the patient exactly whether it is on the left side or in the right side and other things. So this is how we will be demonstrating. We'll be placing a light here, and we have to ask the patient where the line is coincide. If it is straight onto the light, it is an ortho, as we said before. If it is on exactly on some other number, it means the patient has this much degree, or example 2 degree or 4 degree of deviations. This is done for both near as well as for distance. So as sensory evaluation is done, I hope the sensory evaluation part is quite clear for everyone. And now it is a motor evaluation. So motor evaluation, we need to know different things, and the first things will be cover test. So in cover test, we have different types like cover uncover test and alternate cover test. So how we can perform this? So it is again an objective test where we need patient's cooperation, but patient's response is not needed. The equipment which we needed is translucent or opaque occluder. Translucent will be easier for us to examine, to see the eyes, where opaque will be much more difficult. Whenever you take it off, you have to be a quick response to observe the eye movement. And then it should be done for both distance as well as for near. You can use such kind of toys, or fixation cords, or numbers, or any other things. And especially in case of children's, you can have some attractive lights and other things, so that the patient can or the kids can able to see it. So how we can perform it? So in case of manifest deviation, as we already know, the one eye will be deviated outside, and it without any test, we can able to see that the patient has some deviation from the center part, from the center or from the ortho. In that cases, you have to use opaque occluder or a translucent occluder, occlude one eye, and you have to see an uncovered eye. That is, you have to cover one eye and you have to see the uncovered eye. So this is way more important. So when you're seeing that, if the uncovered eye will take a fixation, it means the patient has a manifest deviation, and the manifest deviated eye can also have a better vision, so that it is taking a fixation back. If there is no movement, it means the patient does not have any manifest deviation, or the patient can end up with the eccentric fixation, or else the patient might have a poor vision or less vision in the deviated eye. What in case of latent deviation, that is fourier deviation? In case of fourier deviation, you have to cover one eye, and you have to remove the cover, you have to see the covered eye. So you have to see the covered eye. So you have to make sure to observe the eye movement as much as fast as you can, so that you will be seeing the deviation, whether the patient has what kind of deviation the patient has, because in this the Hirschberg will show center, and the patient might have a good fusional parameters. Whenever you're breaking this fusion, you can observe the patient have horizontal or vertical deviations. So this is how you will be seeing latent and manifest squint. So to repeat the same thing, in manifest we are occluding one eye and we are seeing the uncovered eye. In latent we are covering one eye and you're seeing the movement of the same covered eye by removing it fast. So now it is an alternate cover test. In alternate cover test, again we can able to see manifest deviation as well as the latent deviation. But in alternate cover test, we'll be seeing the speed and recovery. So again, we have different types. So we'll be seeing the types of what kind of deviation the patient has and the size of deviation. In case the patient have very minimal, a slight deviated, uh, or else it has a very small deviation of 15 degree, or if it has a moderate deviation of 30 degree of Hirschberg test, or it has a markable deviation of more than 30 degree. Those things we will be checking, and we have to see how fast they are taking the fixation. If it is rapid, if the patient can able to take a rapid fixation once you covered an unaffected eyes, then it says the patient has a reasonable vision or else a good vision in the deviated eye. If it takes a bit slow response or bit slow take up of fixation, then it indicates a patient might have poor vision. If the patient have a wandering uh, eye movement or wandering indicate it, the patient might have a poor vision or non-fixation, or the patient might have very low visual acuity as well. In case of latent deviation, again we have to see the times, and we have to see the deviation, like what is the size of deviation based on the movement, how far the eyes moves and come back to the ortho position, and we will be seeing the rate of fusion. So in this latent squint, we'll be seeing how fast it is, whether it is a fast fusion, or it is a poor, or it is very poor. So we'll be ranging based on that, whether it has a good fusional, or it is a moderate, or it has a poor fusion or recovery. So for the quick tips, if all the test, if in your cover test, if you get a positive result, it means it is a manifest squint. It has the patient has present with manifest squint. If it is covered, uncovered, the patient have response with it, then it has opportunities, or the patient can be entered with latent squint. If the patient have alternate cover test, and then the patient might have ended with alternate squint. If all the tests will become negative, it means the patient might have no squint, or else the patient can be ended up with pseudo squint. If at all there is another possibility of gross eccentric fixation, the patient can ended up with eccentric fixation, the where the light rays or the images will not fall exactly on the fovea but on the peripheral part of the fovea. And the other possible thing is no vision in the deviated eye, or else less vision in the deviated eye. So the only parameters which can affect in this in this cover test is patient's vision and cooperation. So how we can measure this? Yes, we can measure it with the help of various devices, uh, where we commonly and widely using a standard method of prism bar cover test. The cover test or the uncover test, alternate cover test, whatever I have said previously, will help you to measure how much degree of deviation it is. And it is a very standard measurement to measure the angle of deviation. So always remember the prism apex should be towards the deviated side, or else the base should be opposite to the deviation side. As I've already mentioned, ESO it will be base out, EXO it will be base in, hyper it will be base down, and hypo will be base up. And we have different types of prisms, like bar prism, loose prisms, and other things. And in this case you can also see corneal reflex, like you can also perform Hirschberg test, as well as you can do the prism test as well. So what are the advantage of this test? So we will be doing this test in virtual classes, so that I'm not going to put any videos in it, because we are going to put it in a practical as a live section. So what are the advantage? It is an accurate measurement, as I've said before. It is performed under natural condition. The patient does not want to do much things, just they have to sit simply and they have to concentrate on the one single target. And the other thing is, it can provide maximum angle of deviation. How much ever the angle of deviation it is, the patient, and we can able to measure it. And what is the disadvantage of it? If the patient has a central fixation in both the eyes, but the patient's visual acuity is less, it is quite difficult to maintain it, because patient can't able to fixate the distance object or the fixation target. And it is quite difficult in doing with a patient who are very young or very uncooperative patients. And we have a certain limitation of the prism bars, but nowadays we have the availability up to 60 prism diopters, so we can able to measure up to 60 prism diopters in the market as well. So here, in case of very poor vision, yes, we have other tests also to measure it. We have like Krimsky test, modified Krimsky test to measure it. So this prism alternate cover test will not help in the patient who have a poor fixation or poor visual acuity. So the next one will be extraocular mortality test. Extraocular mortality test, before evaluation, you have to get a better idea or a clear cut idea of how your extraocular muscles works on, and what are the nerve supply it has, and what is the primary, tertiary, and secondary actions of these muscles. So I don't want to go into much detail about the actions. I will just give a small recap of all other things. So your superior rectus will have an elevating property, your inferior rectus will have a deprivating properties, where your lateral rectus will have an adducted, and your medial rectus will be having an adducting properties, and your inferior obliques will be having extortion, and your superior oblique will have an intorsion of its action. So there is another point where you can able to simply memorize in a simple point of view. So whenever you're doing extraocular mortality test, will be using a broad hedge test, where it will be evaluating each position and each muscles. So as you already saw, we used to move the finger, we used to keep a light, or we used to give a target from here, and we used to move the target, so that the eye will also move along with the target. So if you are moving outward, it gives rise to a lateral rectus, whether it is underacting or overacting. If you move inward, then it gives you an thing of whether it is overacting and underacting of medial rectus. So this is how it happens in all other six muscles. So you also knew that elevation means up, depression means down, and adducting means it is going towards the medial or going inward. Abducting, it means it is outward or going towards your temporal side. So these are the basic actions where you are where you'll be seeing. And all the recti muscle will be an adducting muscle, all the oblique muscle will be having abducting as a tertiary actions. And while you're coming to the lateral rectors and medial rectors, you don't have secondary and tertiary action, they have only a primary action. And when it comes to a nerve supply, we have three nerve supplies. To have a mnemonic of it, we have a simple mnemonic, that is LR6 and SO4, which says that lateral rectus will have a sixth cranial nerve supply, which is an abducen nerve, and your superior oblique will have a fourth nerve, which is a trochlear nerve, and the rest of all other muscles will have an extraocular motor nerve, which is a third cranial nerve. So hope this is quite understandable. So we can see how we can measure it. So in that we have two types of measurement. First one will be the duction test, and the next one will be the version test. As we have seen this terminology in the beginning of our presentation. So duction test, how we can perform it. So every test, make sure you have to sit straight opposite to the patient and maintain the eye level of the patient with an adjustable chair, so that it will be more accurate whenever you're doing any test, just like whatever we have discussed for as of now. So in this we have to occlude one eye, and we are going to see the movement of another eye. Now I'm occluding the left eye and I'm seeing the movement of the right eye. So based on that, I'm going to grade them from -4 to +4, which where -4 to -1 will have an underaction of the muscles, and +4 to +1 will have an overaction of that muscles, and it will be done monocularly. We'll be seeing the test of whether the adduction, abduction, elevation, and depression is working good. So then we have a version test, which is a binocular test, and in this binocular test, it is more evident, so that you can able to measure each muscle's action, and you can able to see whether the muscle is overacting or underacting. So whenever it comes in the right cases, it has a mnemonic of it has a prefix called dextro, and if it comes in the left side, then it has a levo as a prefix. So to put it in a term, right side will be have a dextro and left side will be having a levo. So based on that, we will be discussing the other terms. So this primary will be the primary or ortho position or a stride position. It is an elevating position from the primary, and full down it is an deprivation. So here are the muscles which is helpful for this action. When it comes in the levo elevation, your inferior oblique and your superior rectus will be acting. When it goes to the extreme left, that is levo version, and this is levo depression. Similarly, you will be having a dextro elevation, dextro version, and dextro depression. So based on these parameters, we'll be seeing like which muscle is overacting and which muscle is underacting, or else we will be checking whether there is any restriction or any restrictions on the muscles. So if the patient have any paralytic squints or any nerve palsies, they can end up with some parameters, like they can end up with this restrictions, which is very prominent in paralytic squints. So for a quick tips, excessive and defective movement in all direction can be easily assessed with this extraocular motility of version test. And if one action of one muscle is overacting, the other muscle will be having an underaction. That is, an contralateral synergic muscles will have a contralateral things, which one eye is weaker and the other muscles will be taking part of overacting and to compensate the muscle reactions. And we have another thing which is a Duane syndrome. In Duane syndrome also you have different types of Duane syndrome, but to be having a basic thing, when you do this version test, you'll be seeing there will be a retraction of a globe at one particular direction. Mostly it will be abducting, adducting, or it can be a mix of abducting and adducting muscles. And in that particular point, there will be a narrowing of palpebral fissure height, or else the palpebral fissure height will reduce in certain direction. So this will give rise to an idea of Duane syndrome, that is lid retraction Duane syndrome, we used to call it in a term. So I hope all these tests are quite understandable. So we can put it in a video thing. So I will show you what happens in the squint. So now you can see, and here we don't have access for the distance and near. It all comes in the under a near one. So here, can anyone say that what kind of squint or what kind of deviation the patient has? You can put in your command section if it is possible.
Answer in the chat box, everyone.
Mhm.
Okay, so we have an answer here,
Mhm.
exotropia, left exotropia.
Yes, exactly. It is a left exotropia. And here, first, I'm going to place the occluder on the right eye. So I'm seeing and observing the left eye, that is uncovered eye. So this is how your cover test works on. So here the left eye is taking fixation. It means the left eye has a good vision or a moderate vision. So now I'm going to do uncover test. In this cover uncover test, I'm going to have a foria. So I'm going into foria test. So I'm going to cover one eye, and for a fraction of second, I will take it immediately. So you can see the covered eye has been deviated. So you can see it once again. It is the right eye going into an exo. So I'm taking in the cover. So the right eye is taking fixation immediately. So it means uh, the foria, the patient has an exophoria. Okay, so I hope this is what the cover uncover test will act as. And what happens in the alternative squint? Yes, so what happens in the alternative cover test? Here I have a occluder where I'm placing one in one eye and the other occluder in the other eye. So simultaneously, I'm seeing both the eyes. So I'm seeing both the eyes whether it is taking fixation. By giving a single fixation, I'm seeing both the eyes. So you can see the both eye is deviating and it is taking fixation from the center. And immediately when I allow them to take a fusion, when I allow them to take the fusion, the eye comes back into the normal. So this is what happens in your cover, uncover, and alternate cover test. So hope this is understandable and how we can measure it. So here we can go with a manifest, so it will be a bit more easier for you to understand. So again, I'm going to manifest squint. As you have all said, the patient has an left exotropia. So I'm giving them a central fixation target. And now I'm taking a prism. So is there any idea like how the prism should be placed, whether it is a base in or base out or base up or base in? Can you go with an command section?
Apex towards deviation is the leading answer that I can see right now. A lot of
Okay.
people are saying base in as well.
Mm-hmm. Okay, we can go with an majority thing like apex towards the deviation. So here you can see the this is the prism, and here is the one second. This is the prism, and here you'll be having a base which has a shadow in it and a sharp line. It is an apex. So I'm placing the apex towards the deviation side. So you can see that your eyes is getting inward. So you can see the difference. Your eyes is getting inward. So now I'm placing a 20 prism diopter of base in prism. So it says like 20 prism diopter is not enough. But when you're doing in an clinical OPD, you have to start with weaker prism, and then you have to slowly increase the prism strength. And now, I'm sorry. So now I'm covering one eye. So I'm increasing the prism strength. I'm placing the prism in one eye and I'm doing an alternate cover test. So still there is a movement. So it means we need bit more strength. So I'm increasing the strength. Now I'm placing the prism in front of one eye. Now I'm doing an cover test. So alternate cover test. In this alternate cover test, you can see now there is no movement. This is what our end point should look like. For a cross confirmation, you can increase the prism diopter once again, place it and do an alternate cover test. Here you can see the fixation. The eyes is moving from in to out. That is the opposite direction. The eyes is moving in an opposite direction. It means you have increased the strength more than the expected value. So you can again reduce the prism and you can check it once again so that you will get an idea that the patient has 30 prism diopter of left exotropia. So hope this prism cover test is quite clearer. So this is how works in hypo and esophyxia and this 4 years as well. In 4 years, what used to do is I will give an example for 4 year once again, and then we can go with an EOM actions. So in 4 year, I'm going with lesser. I'm doing an alternate cover test. So the patient have a very minimal deviation where you can able to see the patient deviation is much quicker. It means the patient has a very good control. So now as you all said, I'm rotating the prism towards the deviation size. As it comes from in to out, I'm placing this in front of patient's right left eye, right in front of left eye. So I'm doing the cover test once again. So here you can see there is still a movement. So now I'm covering one eye. I'm taking the prism and increasing the strength, placing back into the eyes and doing the alternate cover test. So here you can see again there is no movement. So it means the patient has base out prism like a left or a base out prism of 10 prism diopter. This is how you'll be measuring for both tropia and phoria. And I hope this all is quite clear and we can quickly fresh up with this restriction in extraocular muscles. So I'm going to uh, undercorrect or underaction of lateral rectus. So in case of lateral rectus underaction, what it happens is, so now we are not going to use this occluder. So this is a target and I'm placing the target. Now you can see when you're deviating towards your left side or as your lever version, your lateral recti muscle is not acting. It is not going further because it has a -4 degree of underaction. So here, yes, dextro version it is full, dextro elevation it is full, and dextro depression is also full, version is full, center is full, and elevation is full. And then you're going straight into the levo elevation. Levo elevation is also full, and you're going into levo version, it is underacting. So now you will get an idea which muscle is underacting. And then you're also going down, that is levo depression, it is also fused. So if you have an idea of primary, tertiary, and secondary muscle action, it will be much more easier for you to nerve palsies or any other kind of traumatic, paralytic restrictions. In that cases, primary and secondary action will also take place because the particular muscle itself will not have any actions in it. So this is what happens in your eyes as well. Hope this is quite clearer for everyone. And these are my reference where I have took all my preparations. And if you want, you can go through these books as well. It will give you a better idea of how it all works. And thank you for all your cooperations, and thank you. My extend gratitude towards Neuroptech for giving me such an excellent opportunity.
Thank you so much, ma'am. That was an absolutely fantastic session. The way you combined explanations with visuals and videos kept everyone engaged throughout. You made every step of squint evaluation feel so clear and doable. And I think all of us genuinely learned a lot today. We truly appreciate the amount of effort that went into preparing and delivering this. Now, let us move on to the second stage and the last stage of the webinar. We're moving into the Q&A segment. So attendees, if you all have any questions, just drop them in the chat and I'll take them one by one. Okay, so we have our first question, which is the most relevant stereo acuity test?
Yes, relevant stereo acuity test. Like relevant in sense, you can use everything, but if you take a standard, if you so-called standard thing, then you can go with a random stereo test, which is widely used and it is quite standard as well. But
Okay,
every
and we
stereo thing will works good.
okay, all right. We have another question. How can we differentiate between underaction and palsy?
Yes, it is quite interesting when you can get an idea about the palsy. You can able to compare with both the things. So as of now, I have only undertaken this non-paralytic squint. So if you also go with a paralytic squint, you can able to correlate between these two things, and that's how you can able to uh, identify or figure it out whether it is a paralytic or non-paralytic squint. And as I've already said, in paralytic squint we have much more other tests as well. And in EOM, like in an extraocular mortality test also, you'll be having a restriction of muscles, and it will involve all the primary and tertiary actions as well.
Okay, and another question is I think it's about the time you were showing us the visuals. The question is, ma'am, initially both eyes were showing deviation while doing CT. So, how can I detect which eye has deviation?
So, in case of alternate a squint, or in case of ideas, which is called as intermittent divergent squint. In intermittent divergent squint, everything we won't particularly mention which eye it is. We'll be mentioning like which kind of deviation the patient has. So, whether the patient has an ESO deviation or EXO deviation. In case if it is a manifest squint, then you will be get an idea that right eye is deviated either in or out. So based on that, you'll be measuring like right eye exotropia, this much PD and this much thing will be measured. But in case of 4 years or in case of intermittent squint, we'll be measuring it as in a PD, and we won't measure, we won't be mentioning the specific eye because it is keep on alternating.
Okay, and another question that we have, I think it is not a clinical question, it is something to do with the resources that you have specified at the end of the session. So it's
Mhm.
about, could you please specify the website or app name? It will be very helpful for the attendees.
Okay, and it is an American Optometry Association. They have ended up with this kind of stimulations. So you can search into their websites. They have developed with various softwares like basic squint evaluation, advanced squint evaluations, and other things. So if you go into the website, you'll be getting this kind of stimulators. In that you can practice it, so it will be a bit more easier.
Okay, okay. If any attendee has any more question, you can ask. Now is the time. Okay, I don't think there are any more questions. That I think suffices that the session was indeed too good. I think they all have got their doubts cleared. All right, thank you everyone for your questions. And once again, a huge thank you, ma'am, for taking the time to be with us today. That wraps up today's webinar. We hope the session helped you all understand squint evaluation in a clearer and more practical way. As you all know, Neuroptech continues bringing focused clinical discussions like this. So keep an eye out for our upcoming sessions. This is Shazia Shabir, your host for the session, signing off. Have a great day ahead, everyone.
Thank you. Thanks a lot.